Your mic is muted, May.
Thank you. I'm just sorting through. I got kicked out and then back in. So we're giving everyone a few minutes to join in, and then we will get started. All righty. So we're a couple minutes in already. Just to be mindful of time, I'm gonna get our session started. We still have people joining us, and so they'll kind of come in as we go. But I just wanted to say welcome to our fourth National Neonatal POCUS Collaborative Webinar. We're really excited to have a great speaker today. This is the first in a three-part series on lung ultrasound. I will be your moderator. I'm Dr. May Chen, and I will be introducing our guest speaker. Just a couple of housekeeping. The chat and the audience microphones are disabled, so please use the Q&A feature to post questions, and we will answer those questions during the Q&A session that follows Dr. Yousef's talk. This webinar is being recorded, and it will be uploaded to the collaborative website, which is NeoPocusCollab.com. And then our guest speaker today is Dr. Nadya Yousef. Dr. Nadya Yousef is an attending neonatologist and deputy head of the NICU at Paris-Saclay University Hospitals in Paris, France. She is a self-professed POCUS enthusiast and is active in teaching and training internationally. Dr. Yousef is a member of the POCUS Working Group of the European Society for Pediatric and Neonatal Intensive Care and is the co-founder of the French Society for Pediatric and Neonatal Lung Ultrasound. She has published extensively on the subject of neonatal lung ultrasound, and we are so very excited to have you speak today. Dr. Yousef, please go ahead and take it away. We'll have Karina stop sharing her screen, and Dr. Yousef will be able to do hers.
Thank you very much for this kind introduction, May, and thank you for inviting me to be part of this incredible initiative. I'm really, really excited. I had challenges sharing my screen, but it worked, so I'm sure we'll be able to make that work again. So the title of my talk today is Reflections on the Neonatal Lung. And for those of you who are already performing lung ultrasounds, you will understand why I've chosen that title. To start with, I have no conflict of interest to declare. So lung ultrasound is a point of care technique that we as clinicians perform at the bedside. And we usually have a specific question. We are looking usually for yes or no answers to rule in or to rule out certain things. And we can repeat that examination as many times as we want to at the bedside to get the qualitative information, and sometimes quantitative or semi-quantitative. And lung ultrasound, just to be, clear, does not in itself give any useful information if we do not have the clinical history and the context. It is an examination that is an extension of our clinical examination and our monitoring tools. But what we're actually seeing on the screen are just shades of gray, as I will show you. If we do not know what we're looking for, or if we do not know the patient history, it doesn't really add the information we're looking for, which is why looking at from another point of view, because we, the clinicians, are performing this examination, because we know specifically why we're doing this, because we're not only looking at the screen, but integrating the findings into our clinical assessments, it becomes such a powerful tool. We do have evidence-based guidelines for critically ill newborns and pediatric patients. These guidelines were issued by the ESNIC in 2020. And there is a chapter on lung ultrasound. So today we're going to talk about lung ultrasound in the newborn baby. And there are several specificities in that age group. First of all, they are easy to scan. They're small, they have a small thorax, and in the beginning, at least, they have a few chronic comorbidities. But our challenge as neonatal clinicians is that we are faced with very specific diseases where we need to make decisions regarding management that can be really different, and we have no satisfactory gold standard. And I know I'm no longer on X anymore, very hateful forum, I find, especially if you're reading the French comments. But I've understood it that there has been a huge debate regarding the use of lung ultrasound in neonatology. Very interesting. As I understand it, the non-believers, or I don't know how to call them, are looking for more evidence before they want to start using lung ultrasound. And I totally agree. It has to be evidence-based. But going back to what we're using as our gold standard to diagnose neonatal diseases, most of us are using chest x-rays. And I don't know if you know how many children or newborns were examined using chest x-ray for the diagnosis of RDS before we started using it as our gold standard. It was less than 100. So basically, if we really want to go towards evidence-based medicine, we should be doing that for all our tools. Nobody has ever, as far as I know, really evaluated the diagnostic performance of chest x-rays for the different neonatal diseases. And it's high time we did, because our babies deserve better. In addition, of course, we have increasing concern about potential long-term effects of exposure to radiation, especially if we're doing this again and again. So how does lung ultrasound work? Ultrasound, for those of you who are familiar with this technique, my apologies, ultrasound beams cannot go through air. They're stopped by the air, just like they're stopped by bone. And here we are having a webinar on lung ultrasound. Well, what happens is that when these ultrasound beams reach the lung, they will generate artifacts at the intersection between the air and the fluids in the lung. And these artifacts are dynamic. And in our clinical context, the lung lesions are always or almost always in contact with the surface, which means that we can pick them up. Lung lesions usually have at least a small point of contact with the surface, so they become visible to us. And they can usually be quite extensive. But the limitations, which every technique has its limitations. And for lung ultrasound, or for ultrasound, that is that for us to be able to see the lung lesions, they have to be in contact with the lung surface, which means that, let's say theoretically, if we have this huge lung tumor, which is surrounded by air, this is not something we usually see in our clinical practice, but let's see adult pulmonologists, we would not be able to see that tumor. In our context, because this is never really a problem, but we need to know this limitation. And that means that if your lung scan with the results of that scan do not make sense, they do not make sense according to the clinical picture or to the clinical course, a baby is not doing as expected, please do a complementary imaging technique, for example, chest x-ray. And that is also why lung ultrasound as a technique can never fully replace chest x-rays. However, as you will see, it can be very useful and fill in the gap where chest x-rays are not that performant. Another thing is that today we're not able to evaluate for overdistension. Let's say you're ventilating a baby on high frequency, jet ventilation in the US, I think we use high frequency, HFOV. Once you've aerated the lung, it's difficult to use lung ultrasound to see whether it's just normally aerated or if it's too much aerated. And of course, like with every examination, you need to be systematic. So what I would really suggest you do is that for every baby you will be scanning, you need to scan the anterior, lateral, and posterior lung regions. But do not turn your baby around. You will see in the picture that it's really easy on a baby, for example, who's supine to scan the posterior lung areas. Always do a full examination, the whole of the lung, all the way down to the diaphragm, to be sure you have not missed anything, lateral and posterior as well. And I would recommend starting with the vertical scan, that is to say the short axis, because then it's easy to be sure that you're scanning the lung. And if you want to have some complementary information, then you can go on to do a long axis. In neonatology, we usually use linear or microlinear probes because they're very superficial. However, it would be interesting to see whether we should start using the microconvex probe to be able to evaluate the B-lines, but that is another subject. So as you can see here, this is a mannequin. She's around 600 grams. We're using a hockey stick probe, and you can see doing a whole scan of the anterior, lateral, and here without turning the baby around the posterior is quite easy. It doesn't take much time. And the short axis, which is here, so the longitudinal scan, and the long axis. So we need to be systematic, and the first thing we need to be sure we're doing is actually scanning the lung. And this is where we need to look for the bat sign, and this is what we get in the short axis, so the vertical scan. What we will see, we'll try and find the ribs, and if the rib is ossified, we'll get acoustic shadowing behind each rib. Above that, we have the subcutaneous tissue, muscle, and so forth, and then we will reach a brighter line. This bright line is the pleura. We can't actually distinguish between the parietal and the visceral pleura by the naked eye, but we have a way of being sure that they're sliding together. Daniel Lichtenstein, who is the father of lung ultrasound, and with whom I've had the privilege actually just finishing my second course with him, he uses a microconvex probe, and he shows that this is a rib, this is the second rib, and in between you have this brighter line, the pleural surface, which he says looks like a bat. On a linear probe, it's more of a square, but always start off by identifying your intercostal space, the ribs, the pleural line, and then you will look carefully at this pleural line because this is where things start. And for me, the most important part of any lung ultrasound examination is assessing the movement of that pleural line, what we call lung sliding. Lung sliding is the back and forth movement of the pleural line synchronous to respiration, as I will show you here. For me, this is the most important part because absent lung sliding is never, ever normal, and you have to find out why. As you can see on this scan, we have two ribs, and we can see this brighter line, which is the pleural line, and if you look carefully, you can see this back and forth movement of the pleural line. Right underneath this arrow. This is the area you need to be looking at. This is normal. And if you then do decide to do a longitudinal scan, so the long axis transfer scan, you will not see the ribs anymore because they will have been, disappear. You're going between the ribs, but you will be able to see the pleural line and lung sliding. And if you're not sure, then you can do an M mode. And if you see this M mode, you will see there's a difference between the subcutaneous tissue. They just give you horizontal static lines because they don't move. And then when you come to the lung surface below this blue arrow, you have this fuzzy appearance. Daniel Lichtenstein says it's a seashore sign. So the fuzzy looking part is sand and the lines are a calm sea. This is the part where you have the most tricky thing if you do not have the correct machine settings. You do not need a specific machine to perform lung ultrasound. We usually use a linear probe in the newborn, but you can basically use any probe as long as you can recognize the patterns you see on the screen. However, modern machines are really sophisticated. Often you've got lots of filters in your presets and harmonics, and they can make lung sliding very difficult to see. So you need to be sure you're able to recognize lung sliding every single time there is one on your machine. Otherwise, you will have a lot of difficulty. And just very quickly, you can see how easy it is to spot the difference. This is not a normal lung, right? Or the lung could be looking normal, but if you do not have the dynamic video, you wouldn't be able to see here that this pleural line is not moving. So this is abnormal. Or here again, there is no movement here. So this is always pathological. Once we have identified whether there is lung sliding or not, then we'll try and get an idea of the lung aeration. So what does happen in a normally aerated lung? Well, then the ultrasound beams will go as far as they can get until they reach air, and then they will bounce back and forth and back and forth and back and forth. And what we see on the screen are these repetition artifacts of this pleural line. So basically they are horizontal equidistant lines that tell us there's air in the area we're scanning. It could be normal, it could be abnormal, but there is air. And if we look at our normal lung here, you can see that where there are the red arrows, not only is the lung sliding, but there are also these horizontal lines over here. And these are A lines. So this is a normal lung because there's lung sliding and A lines. But usually we're dealing with lungs that are sick. There's some kind of form of edema, inflammation, and so forth. What happens then? Well, then the ultrasound beams can go even further down. They will generate artifacts called the B lines, because it comes after A, that arise at the pleural line and are the reflection of the increased fluid components in the lung. You can have a few. It's normal to have up to 2 B lines in each intercostal space, but you can have more and more until you find this completely white-looking grass-ground appearance when you have severe interstitial syndrome. And usually in our context, we see more like a generalized pattern. It could be cardiovascular causes or neonatal RDS, or if there is inflammation with increased capillary permeability. But as you can see here we have a few B lines over here, not that many. This becomes much whiter, and here there are so many B lines that we're not able to actually count them. So this is a decreased loss of aeration because it's a ratio always between the air and the fluids in the lung. And then when the lung is completely non-aerated, when it has collapsed, when we have consolidation, this is the only time we actually are able to see the lung. It looks like a tissue. It's kind of grayish. And sometimes we have these white spots in the middle here called bronchograms, which is trapped air. And we can have irregular borders, the shred sign or the fractal sign. We can have very tiny consolidations or larger ones. And sometimes we can have some associated pleural effusion like here. So you can see it looks suddenly much grayer, and the pleural line is difficult to say whether it's sliding or not. And some classic signs have been described in older patients, difficult to apply today in neonatology, but usually if these bronchograms like here on the right side of my screen don't have this back and forth movement, we probably suspect there is some retractile atelectasis. And if there is movement in and out, this is often associated with pneumonia, but of course, in our context, I would say rule out pneumonia because it is difficult to really see the bronchograms in these tiny patients. And then very quickly, pleural effusion, which is something that we often pick up in the NICU. It's usually a hypoechoic or anechoic space, but not always. And what's very important there is to actually know where you are, to be able to identify the structures around. So if you're using a low frequency probe, which may be used maybe in the PICU, you will see this pleural effusion here, whilst we're more often using a linear probe. And you can actually see very, very tiny amounts of fluid like here. With this probe, we can see amounts from 10-15 milliliters as compared to an adult's 100 milliliters on a chest X-ray. So this is for me the slide that really summarizes what lung ultrasound is all about. A normal lung is 98-99% air. And then when you start having edema, you have the B lines appearing all the way to the completely white lung appearance. The only time when you only have air is when you're scanning an area of pneumothorax. And then at the bottom of the spectrum, you have non-aerated lung, atelectasis, and consolidation. And before you ask me, what's the difference? Atelectasis is just a form of consolidation. It's when it's retractile, uncompressed. But on lung ultrasound in the newborn, you cannot really see the difference easily. It's the clinical course that will show. So what about the baby? What's very challenging with the baby is if you apply a data and literature from older patients is that they usually have normal lungs that will go on to have edema or inflammation, whereas we have babies born with wet lungs that will be aerated. So we have to kind of integrate that in our assessments. And the questions we might be asking, if we have a baby with respiratory distress, especially in the transitional phases, is it RDS or is it TTN? So do I give surfactant? Do I need to admit this baby to the NICU? Maybe it's something else. Is it pneumothorax? And if you remember the pattern for normal lung, this really darkish. And in the transitional period, babies can have multiple B lines that give it a more mixed appearance because they're still clearing their airways. And what we've learned is that it happens really quickly. Within the first 20 minutes of life, you have a sharp, clear pleural line that will appear. And then gradually within the first 3-4 hours of life, the lung clears. There is lung clearance that occurs and static compliance increases. So basically it's a 1, 2, 3, as in this study of Francesco Raimondi. So what happens if babies are not transitioning that well? They do have some respiratory distress. They have delayed fluid resorption. What do we see on the ultrasound scan? Well, basically, what I really like about lung ultrasound is that it gives you an insight in the pathophysiological processes, or physiopathological processes in the lung. So what is TTN? It's delayed fluid resorption. So what would you expect to see? Well, you would expect to see some areas, especially the basal areas, that will be more fluid filled than the apexes. And this is exactly what you see. You're seeing areas that, like here, have multiple B lines, and other areas that have a normal pleural line with A lines. Sometimes you have a very clear-cut distinction, sometimes you don't. But the fact that you have lung sliding everywhere and that you have areas really with gravity, although sometimes it takes some time for that to have an influence on the newborn baby, this is really highly suggestive of delayed fluid resorption. And it has been shown that by just using these simple patterns, you can at an early stage predict which babies will need to be admitted to the NICU for respiratory distress. So what about, so black is normal, black and white is delayed fluid resorption or transition. And what about RDS? So RDS is surfactant deficiency within a certain threshold, which then leads to alveolar collapse because there's high surface tension and so forth. What would you see? Well, first of all, you would see that both lungs have the same changes. There's no reason where you would have, partial surfactant, just one area with surfactant deficiency. Now you see that it's very difficult to distinguish and see this pleural line. It's thickened. It's often gives this irregular aspect because there are multiple tiny consolidations, these micro consolidations, often called subpleural consolidations. And the rest is you've got so many B lines that if you're using a linear probe, you cannot count. It gives this white lung appearance that could look something like this, for example, or something like this. But you always have conserved lung sliding. And the difference between RDS and TTN is that you wouldn't have what we call spared areas in RDS. Why would you have any areas that are spared, meaning that they have a normal pleural line and A lines? You have universal surfactant deficiency. Whilst in TTN, at least in the classic cases, you are gradually, resorbing the fluid. So you have areas with B lines and other areas that have been cleared. And it's quite easy to be able to distinguish between these two patterns. You don't need a lot of experience. So here is the challenge, and here is where we are, right? We have guidelines, be it the US guidelines, North American guidelines, or the European guidelines, that tell us as neonatologists that we need to give surfactant selectively, and we need to give it early within the 3rd hour of life if we want to reduce mortality and morbidity. In the European guidelines, our surfactant administration is based on FiO2 levels of 30%. We would agree that this is not ideal. This is the best we have. Or is it? We have, until now, not had any easy bedside tools to estimate lung volumes, but we actually do have one now. And I know you'll have another talk on the use of lung ultrasound and surfactants. But basically using this graphic, just thinking about that, you have different artifacts and patterns that appear with loss of variation. We decided to create a very simplified neonatal score. And we know today that it can predict the need for early surfactant, what we call ester. So we use the term echography for ultrasound in France. So it's echography based surfactant therapy. So basically, each lung is divided into 3 areas: upper anterior, lower anterior, and lateral. We scan the whole lung, and then we score these areas. And according to the patterns we see, we will give a score. Each quadrant or area can get a total of 3 maximum. So if you have less than 3 B lines per intercostal space, so basically 8 lines, you give a 0. If you have a mix of A and B lines, meaning that you have 3 or more B lines per intercostal space, but still you have A lines, we give a 1. If you have so many B lines that you cannot see or hardly can see the A lines, you give a 2. And if you have a large consolidation above 0.521, then you give a 3, and then you add them all up. And what we know is that if you have a score of 9 or above, this is highly, highly predictive for the need of early surfactants. We're around 91%, especially if we integrate other parameters like SAT-RFI2. So you can see that although we're scanning the whole lung, these are the areas we will score. And again, 0, 1, 2, and 3. And we've actually had 3 meta-analyses. This is the 3rd one. And the studies are a high quality. We have over 1,000 babies in here, so largely much more than the chest X-ray babies. And we have 2, there are multiple scores out there, but basically they're either like the spread score that I showed you, or it's a pattern like a 1, 2, 3. Both of them work really well. They have their advantages and their disadvantages. But what we do know today is that we probably have more information regarding the BRAD score than this 1 to 3 one. But it all depends on what would work best for you. We have around 700 babies in this one and around 180 babies in this one. So in conclusion, today at the bedside, we as clinicians only have access to lung ultrasound once we've trained to use it. And we know it's highly predictive for early surfactant, way above FI2 thresholds, work of breathing, and so on. Multiple scoring systems have been validated and we need to standardize. But a lot of questions could be asked on the impact in other settings because all the studies so far have come from high resource settings. And quickly, before I come to the end of the talk, I want to talk about meconium aspiration. Because this is also one of the conditions where lung ultrasound can be extremely interesting, not only to make the diagnosis, although usually we have the history or the chest X-ray, like in this case. And what we see again makes sense. We've got meconium plugging the airways, so we'll have airway collapse, like here, panel C and F. Atelectasis, we have consolidations, we've got surfactant inactivations, so we've got areas with inflammation, and it's very dynamic. So lung ultrasound allows you to get a 3D vision. You can follow your patient up and you can see how this lung changes when you change your ventilation pressures or your management of the patient, if you decide to give surfactant or not, whatever your protocol is. And also, of course, to screen for complications. And often there has been a difference between chest X-rays and the lung ultrasound picture. And quickly then for pneumothorax, which is not specifically neonatal, but for the neonatal period, this is the time in life where we have the most pneumothoraces. If we're scanning the area where we have air between the 2 pleural leaflets, there are specific signs when we add them all together. The first one is that we will not be able to see lung sliding, as you can see here. The reason why we cannot see lung sliding is because the ultrasound beams will not be able to cross the space between the parietal and the visceral pleura. It is not possible because there's air. So we will not be able to see lung sliding. What we will be able to see is the pleural line and then just the repetition of A lines because there's air. And if we're unsure if there is lung sliding or not, sometimes it can be a bit tricky. If we do this M mode, instead of seeing the seashore sign, we will be just seeing parallel lines like this all through the screen. And something that looks like this, where you can see that there is absolutely no sign of lung sliding. This is called the stratosphere sign or the barcode sign. And as you can see, it's different from the seashore sign. if you have these 3 signs, so no long sliding, only A lines, no B lines, no other artifacts that let you know that the ultrasound beams have gone through, then you need to find the point of separation of the 2 pleural layers. This is what confirms your diagnosis. Not only does it do that, but it also gives you an idea of the size of pneumothorax. And when you find this point, you will find what we call the lung point, which is basically on the same screen as we can see here, you have 2 patterns. You have on the right side of the arrow an area where there is no lung sliding at all. And then on the other side of the arrow, you have this lung sliding. Can you see that? There is no other condition that gives this. This confirms the diagnosis of pneumothorax. On one side, no lung sliding, only A lines, no B lines. And on the other side, here we, in addition, have B lines. And the best is to really see this in live, of course, but you can also see in the M mode that you can see the difference when the lung expands during inspiration. You can see it in conventional mechanical ventilation, CPAP, spontaneous breathing, or like here in high frequency ventilation. Here you can really see the difference. It has been tried in the crashing infants, and in addition to having a very high sensitivity and specificity, time to diagnosis was much quicker. And I really like this meta-analysis in pneumothorax because we have a lot of data in adults, and we know that lung ultrasound is so much more performant than chest X-rays for that diagnosis. It is almost in line with the CT scan. And what I like about this meta-analysis is that they grouped neonates and adults, and then they analyzed each subgroup on their own. And you can see in green that for the newborn, you've got a sensitivity of 97% with a specificity of 100%. Which other diagnostic method can give you that? So this is really an added value if you're faced with a crashing infant or an infant with undifferentiated shock. However, the downside, of course, is you're picking up tiny pneumothoraces that have absolutely no clinical significance. So you need to take into account the clinical picture, of course. But basically, what we can say is that if you have this lung point, so the point of separation between the pleural layers that is limited to your anterior chest wall, so basically ends at, let's say, the anterior axillary line, this is a small, insignificant bubble of air. If it is around the mid-axillary line, then it's probably moderate. You might want to consider doing something if your baby is distressed. And if it crosses the posterior axillary line, then this is a large pneumothorax. And this is really probably why your baby is not doing well. Of course, sometimes if you have such a large pneumothorax and the lung does not reach the chest, well, then you might not find the lung points. And what is recommended is if your patient is stable, you then do an alternative imaging technique. But if your patient is crashing in pre-arrest or arrested, then you go ahead and treat this baby because the probability is so high. So where are we today? Lung ultrasound has seen really an exponential growth in the past years, not only for the diagnosis of specific neonatal diseases like RDS, meconium aspiration, TTN, but also to guide management like for surfactants, administration, progression towards BPD, and now we're learning more how to use it to guide our ventilation. What about, in fact, in limited resource setting, there's a lot to be learned there. In practice, it's an excellent investment. In terms of material, it doesn't cost that much. The most tricky part is to have good training opportunities and monitoring possibilities. So I think you guys should be proud because of this national initiative, which is really important. And we're all asking the question of certification for now. As far as I understand, it's basically institutional certification. There is no national certification. And we in Europe, especially with the ESPNIC, with some of the colleagues are here today, we're trying to work on that. So I'd like to thank you all. And if you do come to Paris, please come visit us. We would love to have you. And a quick word about the JEP, which is the French group for pediatric and neonatal lung ultrasound. If any of you are logged in from a French-speaking country, or even if you are abroad and you'd like to be part of our group, please do. We need members. We're trying to train, we're trying to get this technique everywhere really, and to do high quality teaching, mentoring, and research. And we're working on certification, but we have a long way to go. So thank you very much, and I'd be happy to take the questions. I don't know how I'm with time. I've done my best.
Dr. Yousef, you did an incredible job with time and an amazing job with the talk. Thank you so much. We are going to have our panelists open their cameras, basically, and slowly we will introduce you all, but give everyone a quick minute. Make sure that we have all our panelists. Okay. I see people turning their cameras on. Excellent. Okay, so let me just introduce our panelists for today. I think if Karina wants to share the screen for our panelists, but thank you to Dr. Yousef for her talk, and to our panelists for this for joining us today. Our panelists we have today, Dr. Almudena Alonso. She is an attending neonatologist at Hospital Puerta del Mar in Cadiz, Spain. Her PhD was on the usefulness of lung ultrasound in bronchopulmonary dysplasia, and she has many publications on neonatal lung and diaphragm ultrasound, mainly about the use of lung ultrasound for monitoring very preterm infants during their NICU stays. So thank you and welcome. Next, we also have Dr. Monty Sharma. He's an attending neonatologist and pediatric pulmonologist at Children's Nebraska in Omaha. He's also director for neonatal POCUS at Children's Nebraska and a part of the CHNC BPD collaborative. Thank you, Dr. Sharma. And we also have Dr. Eric Sue as our final panelist here. He is an attending pediatric intensivist at Baylor College of Medicine. He has helped found the Pediatric Research Collaborative on Critical Ultrasound, the PERCUS group, within the Pediatric Acute Lung Injury and Sepsis Investigators Research Network, which is a multi-institutional international ultrasound collaborative. Very involved in POCUS research and has numerous ultrasound-related publications. So thank you all for being here and taking time to answer some questions. I think we'll just kind of start off. Our panelists, I really feel, are coming from multiple different countries. And so there are bound to be some differences when it comes to lung ultrasound. I guess one of my questions is, are all babies or patients being admitted to your ICUs getting lung ultrasound now?
Should I start? All babies admitted to my NICU, where I work, with respiratory distress, yes, they will undergo a full lung examination. We hardly do any chest x-rays for that, unless, again, findings don't make sense, or finally the baby does not progress as expected. So that is part of this is our first-line imaging technique. I'm guessing it's the same for Almudena.
Yes, it's the same. Thank you. Thank you, Nadia. Thank you, May, for the introduction. Nowadays, it's been quite a few years ago that we are not using X-rays for our main imaging test for babies with respiratory distress. Even for the smallest ones, for us, it's easier to get some warm gel and get an image of how the lung is going, not just at the admission, but also to see how the respiratory disease is progressing day by day or week by week during their admission in our unit.
I don't know if Monty or Eric, you guys have any thoughts from the US perspective?
I think from a neonatology standpoint, we're definitely not quite there yet, right? I think right now we're in the stage where every lung ultrasound more or less has to have a corroborating X-ray, though we are keeping track of how fast we can obtain lung ultrasound compared to X-ray. So then we can make the case that, hey, this is faster, this is more efficient, and its specificity and sensitivity might be higher too. So much like what Medina was saying, we are tracking serially with ultrasound, which is so much more of a useful tool than repeatedly ordering an X-ray. We can track serial changes. And I think one of the places where we've been a little more successful here has been pneumothoraces, is following resolution of pneumothoraces. Interestingly enough, one of the ways that ultrasound got introduced into our unit was using lung ultrasound to place chest tubes. So procedural things made their way into more of a yes or no management question.
I'll chime in as someone who is way on the wrong side of the age spectrum. I actually am an adult and pediatric cardiac intensivist, and so I think it's really interesting that in the cardiac world, going all the way from the neo patients all the way up to the adults, people are talking more about why aren't we doing lung ultrasound. And a good friend of mine here recently completed some work, which he's working on a manuscript for looking at patients who completed Fontans who had like average base kind of like lung base scores in the 2s upon discharge were more likely to be readmitted back to the hospital. And so I think there's a lot that we're missing. There's a lot that people are talking about in populations that are high risk that we haven't tapped into really yet. The patients with CDH, I think, ever since the day one of their care, you just see so much stuff that, you can manage in terms of lung recruitment, lung disease, just the structure of things like the pneumos, trying to plot your drainage to make sure that they're safe. There's just such a world of things to be doing that I feel like there's a lot that could be worked out more in a protocolized fashion, but in a way that also really benefits these patients.
Thanks. I mean, I think that lung ultrasound, there's so much great utility, not even just in the lung, right? As just like Dr. Sue is saying, even with the cardiac patients, there's so much use for lung ultrasound in neonates and in pediatrics. I guess as we talk about doing lung ultrasound, personally, I have started picking up the ultrasound probe to do lung ultrasound as well in our unit. Do you guys have any kind of technical tips for scanning to improve like the image quality? I think there's a particular question in the Q&A, for instance, like which ultrasound probe do you find the most useful? And can you be specific?
Could I also add on to that question for Medina and Dr. Yousef? And just because lung ultrasound is relatively new in the United States, in addition to the probe type, is the probe orientation. That's a question I frequently get asked. And if you could also kind of elaborate on what the scoring systems are based on, as far as, is there a specific way to orient your probe, whether it's longitudinal or transverse?
I don't know, should I go first? I just want to stress the fact that at least in neonatology, and I think also in pediatric and adult intensive care, this is different than if you're doing lung scans for, I don't know, chronic lung disease or something. We're actually using lung ultrasound as a part of critical care ultrasound. The lung we're checking because it's accessible, because it gives us a lot of information, and because our patients usually have some kind of respiratory compromise, but also it gives us indirect signs of what's going on in the hemodynamic part of things, lung edema and so forth. So it's not really a standalone examination, although usually we don't, I mean, it's probably quite easy to start using if you're working in a context where there's not a lot of point of care ultrasound being done. That will be an easy technique to start with. But in the end, it's kind of your visual stethoscope. So if you're looking at the lungs, you want to check the heart. Maybe if you're doing neonates, you want to check the brain or the abdomen. But then going back to some technical tips, I would say that my most important tip I'd like to give is when you're looking at your machine and your machine settings, even if you have like long presets, just be sure that these presets or when you're scanning that you have the maximum the filter switch off, like harmonics, stuff like that. And be sure that you're able to recognize on your screen, with your machine, with your probe, long sliding, because it can be tricky. It can range from what I showed you to like tiny sparkling. But if you have settings that make it difficult for you, you will not get any additional help from using long ultrasound. It would really be a pity. When it comes to how you orient your probes, being for scoring or other things, what is most of the publications, at least the first ones, you started out with a short axis, so a longitudinal or vertical scan. And this is important for me to start with so that you know you're actually scanning the lung, especially if you, I mean, we have some information like congenital diaphragmatic hernia and so forth. And also the scoring systems, the base are based on per intercostal space, but it's really difficult to use that just, I mean, we see so many intercostal spaces in the baby, so we have to get a global overview. So basically by convention, if you're looking at the screen, it's like the brain. The right side, I don't know, you flip it around, right? It's there is always a convention to where the right side of the patient should be and the left side if you're using a transverse or transverse scan. And it's also where your upper or cranial part should be as compared to the lower part or the caudal part. And this is really by convention. It's following the convention for everything else but the heart, really. Sorry, Eric. We flip the heart around when we're doing echoes, but other than that, we just follow the same convention. And it's also the same when we're scoring. And as you can see, there are multiple scoring systems, but the basis is just seeing how the artifacts are changing with loss of variation. And it can be really tricky to give sometimes an exact answer because you're giving a global overview. Adult scores usually stay on one intercostal space, but we often see 3 or 4. So we need to take some time, maybe turn the probe around to get an idea, is it 25%, 50%, 75%, 100% V-lines, and really integrating this into, what we know about the baby. So I'll leave Almudena to add. She has used many different scores and especially follow-up for the babies and BPD and so on. Yeah.
No, I think I agree with you in terms of lung ultrasound. I mean, we have many reference now to know that which one should be best applied, at least in neonatal patients. Not so many in pediatric, I'm afraid. But in neonatal patients, the classical lung ultrasound score, the one that Nadya has explained in her talk, is widely used, although with some modifications. I would explain a little bit about some settings that maybe can be useful when someone is beginning using this technique. Maybe the ones that have been demonstrated in published articles are those related with increase, as Nadya said, resolution in terms of pleural line, to be able to distinguish lung sliding and pleural line. So it's not the fact that you're using this probe and this other, because Nadya's group published a manuscript as well, in which you can really be able to calculate lung ultrasound score and evaluate the lung using both sectorial or linear probes. But when you're beginning, maybe it's easier to get a nice image or nice pleural sliding when you use the linear probe in the first times. But you can use, I mean, the idea is not, you don't have to wait till you have the linear probe to begin scanning your patients, okay? The thing is that you have to be able to get the nice image. If you don't have a linear probe, maybe you can use, change a bit the depth of the image that you're watching. You can change the place where you place, the place where you locate the focus. You can change the gain in the lower parts of the image. You can do some modifications in your settings so that you are able to see a nice pleural slide, a nice pleural line, nice line sliding, and then you will see the artifacts quite easily, whether the probe you use in your machine and the one you're more comfortable with. Also try to use the probe with the lower frequency, sorry, the higher frequency that you are able to get, because what you really want to know and the structures that you're really watching is the thoracic wall and the lung slide, the pleural line. The others are just artifacts, so you're not really need to have quite a long depth so that you will able to see the artifacts anyway. So basically, it's just begin doing scans, whatever probe you have. If you are beginning, maybe better with the linear probe, but you can also use other as well. And try to get the nicest image at the place of the pleural line, using the place where you place the focus. If you are in small baby, maybe 1 centimeter or 0.5 centimeters. Change the gain at the lowest part of the image. Change the depth and the frequency of the image that you are getting. Okay.
Thank you so much. Yeah, I think all of those are really great tips, especially for those beginners who are just starting to pick up lung ultrasound too, to know that, you know, we don't have to be, we can use the ultrasound machine that we have, we hope, because some of us here, at least in the US, aren't dealing with some of the newer ultrasound machines or have the super high frequency probes. But I have used a L12 before in the past just to get an image. I guess along those same lines, you know, as we're talking about obtaining ultrasound images and storing images, a question came up about how do you recommend programs who are like new to lung ultrasound? How do you manage quality assurance of those lung scans and interpretation? Who does kind of that interpretation for you guys, or make sure that folks are getting the right images and making sure that that's safe?
I can chime in a little bit.
Nadya and Eric, go ahead. You guys are in the US.
Yeah. So this is something that I've been actively dealing with for the last 2 years. I think the first thing as we rolled things out was to standardize the actual process as far as the scan protocol. Like, we will always use a longitudinal view. We will always use the same exact order. So you're more or less speaking the same language from scan to scan. So you could look at it and say, hey, this field is marked for this is marked for this. So initially what we started doing was reviewing our images as a big group every 2 weeks. And as I said, you know, each of these scans would have to have a corroborating x-ray. So we'd kind of go through them and say, hey, look, this is the clinical picture. This is what the x-ray shows. This is what the ultrasound shows. And as we've done more of these, we've actually started to find, well, there's a lot of things on ultrasound that the x-ray just wasn't revealing. So I think that actually increased our buy-in. So it was mostly internal, because when we did reach out to radiology, they were willing to help us review things like diaphragm scans, diaphragm excursion, but lung fields just aren't in their purview. Effusion checks and things like that they do help us with, and we have buy-in from them because we were able to integrate our whole system within PACS. But lung fields really did just fall upon us to have a standardized metric. And much like what Nadya showed with her pictures, we used that as our scoring system. We said, yes, this equals that. And then we all agreed to increase our inter-user reliability that, yeah, we're all saying that that's a 0. We're all saying that's a 1, 2, or 3. So that's where we started with this, and we review them every 2 weeks. Of course, we can't review our images today because I'm here, but that's okay. We'll catch up with twice as many scans next time.
Very cool. Again, I can give you our side of things, which may or may not be that helpful, and I apologize for that. But I mean, please pardon the analogy, but I think of maybe like, you know, infant ultrasound, like, you know, smaller geographic area doesn't mean it's any less interesting. You still have notable features. So like, you know, maybe like a 1 acre lot, and, you know, you've got features that are there. You've got, you know, the house, you've got, you know, maybe like a mountain in the back or something like that. But like then you go to like, you know, push to the extremes, like you've got acres of just expanse that you're just looking at and trying to figure out what's going on. And across size ranges, you might find yourself with these kind of struggles as you get into bigger patients. So I imagine like as you get, you might see that your premium is very different from maybe like your older newborn nursery patient in trying to figure these things out. And so a protocol that crosses all of that is what I would highly recommend. I don't know how people might feel about like sticking with one type of probe, because that helps standardize just the way the images look. In my population, we end up with two different sizes of probes and the images just look completely different. And, you know, when you use a larger probe, you just have to keep in mind objects in the field are actually larger than they appear because you've got that wider field of view. And kind of having, you know, boosting that reliability with like just like keeping things somewhat consistent across your multiple reads is helpful. I actually had a great talk with Shazia Bombal, a recent talk. We were at both that where we talked about some of these things with transducer size discrepancy, and just that if you put a tiny little probe, like, you know, one of the high frequency probes is about a 1.4 centimeter face length versus some of the probes that Jay Kim described for looking for ET tubes were like 4 centimeter long ones. And it's like, if you put those two probes on a patient, are the images that you score going to be equivalent in terms of like the amount of surface area that's covered? And then if you've got diaphragm floating in and out, or if you've got, you know, cardiac silhouette. And I thought Shazia brought up a great point as she laid the smackdown on me, which is just using hockey stick is something that's been seen in a lot of papers, and the hockey stick face length is probably like about 2.5 centimeters long. I think that's a pretty nice size, but these are just my opinions. I don't know if I know that some folks like DeLuca have published on these types of standards, but I know that the field's still maturing, and that's one of the challenges too. It's like you find a quote unquote standard, but something that will grow with you too as your program grows and as you find new applications. The things that I personally find challenging, I would love to hear the group talk about too, is like what happens when you're reviewing scans where people are just cutting stuff off, you know, where you have heart in the view, you have diaphragm in the view. You don't, you know, I'm guessing ribs only get to be a factor late in a patient's course, you know, in terms of the opacity and stuff. But I was just kind of curious about y'all's thoughts with that too.
I think that's where we've had to be really honest, like say that, hey, this is not a good quality scan. I think what I've come to realize is that people appreciate that feedback. And, you know, just since as people build programs, you're somewhat limited by the probe choices you have to buy, right? So I think this is where I'd recommend, if you're in a neonatal setting, figure out what range of patients you're caring for, right? Like, hey, if you're in a level 3 delivery NICU and you're going from like 250 grams up to like 2 kilos, maybe the linear probe will help you standardize. Whereas if you're a referral center that's taking care of 2-year-olds, you might have some benefit from like a curvilinear probe as well for the same purpose and have to have 2 separate protocols. Because yeah, Eric, I'm with you. Like some of my CF patients, I know we have pulmonologists in this talk too, the microlinear probes, it's like tiny compared to them and you're not really going to get a lot.
So I guess along those, there was a question as well in the chat. You know, handheld ultrasounds are a big thing, or are starting to become a bit of a thing. And there are some medical schools who are giving handheld ultrasounds to like every one of their students, for instance, here in the US. The question came up about whether or not you think a handheld ultrasound could be sufficient. I personally find that sometimes for the really tiny babies, the resolution was not as good, but anyone have experience there? And then just before people answer, whoever has their hand up, I'm sorry, but we can't unmute your microphone. So if you have a question, please put it in the chat or the Q&A.
Nadya, you want to answer first?
Yeah, I had 2 raised hands for some strange reason. Sorry about that. No, I'm just going back to what you were saying, Eric, and also you, Monty. I agree. And it's true that in neonatology, once we started going, we were using more and more the linear probe. But like Modena said, when we actually went back and evaluated distinguishing or being able to recognize different patterns using the phased array probe, a micro convex probe, and this hockey stick probe, basically they were more or less the same. So I have a number of existential questions regarding using this linear probe for scoring, for example. It's like you're saying, Erica, it depends on how much are we saying in which patient. And sometimes I feel, I mean, the literature, we have robust literature on that. I'm not saying anything about that, but I'm going also back to what you're saying, both of you, about the quality of images. So just in our experience, we were not able to start in such a very nicely organized way because we're very, very, very understaffed. But that was our strong point. We were able to train everybody at the same time, bedside training, monitoring, you know, buddy system, everything. So everything was hands-on, and this was easy to train the whole team. And now, you know, those who were trained can train trainers and so on. But going back to these different probes, I'm really thinking it would be interesting to see, for example, in neonatology or smaller infants using, for example, the microconvex, which is basically a small curvilinear one. That's, theoretically speaking, could be a very good universal probe, because if we say that lung ultrasound is part of, you know, critical care ultrasound, that would be probably my go-to probe. But that would not prevent us from doing what Almudena is using, maybe following up, looking at specific things with the linear probe when we have more time. But I think there's a lot to be standardized and many questions that remain. And just for information, the BRAD score, the first paper that was published, it was published using a microconvex probe because we didn't have a linear probe at that time. Yeah. And it worked. So.
No,
but they're important questions, and I'm not sure we have the answers. Sorry, Almudena, I interrupted.
No, don't worry. I think the idea is that we are not looking at the lung itself with the ultrasound images. So irrespective of the size of the baby, you will get nice image if you do right with your settings, because the only thing that you're really watching real images will be the thoracic wall and the pleural line. That's it, unless the baby has a big consolidation, a atelectasis or whatever. Okay, so even if you have a 5 grams baby, sorry for using grams, but even if you use a very small baby, the resolution will be quite good. You could have very nice images from very small babies as good as bigger ones, because you're just watching artifacts. Okay. And that's very important, because it's the only ultrasound view in which you're not really watching the organ itself. Okay, so you can get very nice images even if you have a very small baby with relatively not very low frequency probes. Okay, that would be the idea.
I totally agree with Almudena, and that hence the title, Reflections. We do not see the lung unless it's not aerated. So image quality doesn't really mean anything in that. I mean, resolution, you need to be able to identify the pleural line correctly and check for lung sliding, and the rest are artifacts. And the only time you really see the lung is when you have a consolidation atelectasis. It's nothing like other solid organs. We're just seeing artifacts.
I almost feel like that's the benefit of some of the probes that you were talking about, May, is that they might not have great resolution, but as they're both saying, that you don't necessarily need that. I know we're doing a side-by-side study of looking at one of the handheld probes and comparing it and seeing how the scoring is different in the minds of the viewer. And so far, it's been very similar. The only difference is that the wireless probe profile is bigger. So that's like more of a mental block, right? Like, oh, the probe is so big compared to the baby, as opposed to, oh, the image qualities, because when you put them up on a screen, sometimes people can't even tell the difference where it's coming from.
Yeah. Great. Thank you, guys. I think we are a little over time. I will say, let's ask one more question of the panel, and then we'll do our wrap up. I guess a question that came up that I'm actually really curious about is, someone asked about using lung ultrasound for assessment of lung recruitment in your units. And I think even a question, I know Dr. Almudena or Dr. Alonso also looks at diaphragm ultrasound. You know, do you use that and incorporate that into some of your lung recruitment? Or I know we can't look at over distension necessarily, but do you incorporate diaphragm ultrasound into that?
Very interesting question for an introductory talk on lung ultrasound. I mean, there's a lot of references and publications in adult critical care settings about recruitment, maneuvers, and monitors by lung ultrasound, and there's you can watch. We use the same score for BPD surfactant administration they use when they are monitoring RDS that's being recruited or not, and the response to prompt or changes of position of the babies. We're using the same score, and they use the changes in this lung ultrasound score to monitor how the lung is getting recruited. The thing is that this has not been properly assayed in pediatric and neonatal patients. In my experience, it's not easy to monitor main airway pressure that you need to use just using lung ultrasound, because sometimes it's difficult to get an homogeneous lung, mainly in babies with chronic lung disease, in which you may have hyperdistended areas with other areas that's not being recruited and so on. I use it very frequently, and I find it quite useful to monitor in patients with chronic lung disease changes in position, for example, or recruitment of an atelectasis. Now I have a 5-gram baby which has a big atelectasis, and I have been doing some nursing, changing position, and some procedures today. And now I'm going to get the ultrasound again to see if these have worked or not. This is daily use in our unit. We do this with our nurses to see which is the most correct position that the baby would have today, according to how the lung is progressing. But it's difficult sometimes to get the information about mean airway pressure that baby needs when they have not an homogeneous lung. You can do it in an RDS, in neonatal RDS, in the first days of life, because it's easier, because you do have an homogeneous disease. But sometimes, as we have surfactant, it's not that useful in the first moments of life, but only in the most severe patients, in which you are able to see whether if a patient will benefit of increasing respiratory support, or even the need of intubation, and so on. And just a few words about talking about overdistension, because this is something that's sometimes very difficult to differentiate from a normal lung. But when you really have a patient who's overdistended, you can really see a quite normal lung in a patient who has a very severe disease, or a patient that has mild respiratory support and is receiving too much respiratory ventilation. Maybe you can see how the lung is really looking like a pneumothorax, in which you don't see lung sliding at all, too many A lines. You may see 1 or 2 B lines, and you may suspect that this patient is developing overdistension. In chronic lung disease, patients with chronic lung disease, you can see this quite often. Sometimes you need to increase values of PEEP to see how this is improving. And you can use lung ultrasound. We've done it quite a lot of time as well, to see if you're really getting the level of PEEP that baby needs. But for recruitment, it's not that, I would say, that useful as adults and big children can use for our patients. I'm sorry.
Thank you. Yeah, no, thank you so much that was really helpful to kind of listen to and think about. And I think it's a great segue actually into some of our next sessions. So I know, because we are over time, I will say that thank you very much to our speaker and panelists for this discussion. And as previously mentioned, this is just the first in a 3-part series on lung ultrasound. So join us next month for our webinar on respiratory distress syndrome with Dr. Danielle DeLuca, speaking about ultrasound-guided surfactant replacement. Anyone who's on this call can register with the QR code. You can go to our webpage at NeoPocusCollab.com to register. And if you're interested in receiving communication about these future webinars, you can always subscribe to our mailing list on the website as well. And I just wanted to close by saying thank you so much to Dr. Yousef, who gave a fantastic talk, and to all our panelists here. And Thank you so much for answering our questions.
So thank you very much, everyone. Have a nice day, evening to you, Almudena. And
Bye. Thank you, everybody.
bye-bye. Thank you.